Well, hello there.
Well, hi, Nurse T. How you doing?
I am well, Miss Banks. How are
I'm
you?
doing all right. I woke up this morning, and that's a blessing in of itself.
Wow, I agree. I agree. Well, it's good to see you. And who do we have here?
This is my daughter. I don't remember if I introduced you to her the last time I was here.
I remember you talking about her, but I don't think I've ever met her. What's your name, sweetie? Imani. Hi, nice to meet you. Is it okay if she stays doing your
Absolutely.
exam today? Okay,
Absolutely.
good. So you're here for your blood pressure check, correct?
Yes, ma'am.
Okay, before we get started, let me just confirm, make sure I have the correct chart. I need you to state your name and date of birth.
Messiah Banks, February 4th, 1962.
Okay, that would be you. And the other thing I just need to confirm, I have a list of medications here, and I just want to confirm that you're still currently taking these.
Okay.
I have listed the oxycodone,
Yes.
morphine, atorvastatin,
Yes.
hydrochlorothiazide,
Yes.
and the diazepam.
Yeah, I'm taking that one.
Okay, nothing else?
No.
All right. Okay, well, we're going to take your blood pressure real quick and
All right.
see how things are going.
Okay.
Did you have any other questions or concerns?
No, not that I can think of
Okay.
at the moment.
All right. How's the weather out?
I think that we're supposed to have a hurricane or something, but
Yeah, I hear there's a lot of people.
it's probably gonna be nothing like usual.
All right, let me just see here. Okay. So are you having any pain or discomfort at this time?
Yes, absolutely. Just
Okay.
consistently, it's a 10 out of 10.
10 out of 10? All right, and where's your pain located?
Definitely in my lower back area.
Lower back, okay. All right, let's see how this blood pressure is looking.
I'm a little nervous.
After I get your vitals, I'll go and get Dr. Golson, and we can kind of see what's going on with that pain, okay?
All right,
All right.
seems about right.
Okay. Seems a little high. Let's see what we can do about that.
Yeah, that's not a bad thing, is it?
No, well, I mean, we can check your baseline and have the doc take a look at your record and see what we need to do about that, okay?
Okay.
All right. I'm going to stick this under your tongue. Okay. I will be right back. I'm going to go and get Dr. Golson, and then we
right.
can kind of see what we can do about that blood pressure today and that pain and
Okay.
discomfort. Now, where did you tell me your pain was located?
It's like in the lumbar area.
Okay. All right. Okay. All right. We'll be right back.
Thank you.
All right. Hi. Good afternoon, Dr. Golson. How are you today?
Good. How are you, Miss Oliver?
Good, good, good. We have Miss Banks here. She's here for a blood pressure follow-up. She's in room 248.
Okay.
Her blood pressure is a little high today. It's 150 over 96, and her heart rate is 88, temperature 98.6. She is complaining of some discomfort in her lower back. She rates her pain 10 out of 10. I had an opportunity to verify her medications. She said that she's currently taking the medications listed, and she has not had any change in her medication regime to date.
Okay.
And I asked if she was taking any other medications, and she denied that as well.
Okay.
I'm just concerned about the lower back pain, and then I'm kind of concerned a little bit about her blood pressure because based on her previous readings, it's a little high today.
Okay. All right. So you said her blood pressure is 150 over 96.
Yes.
And it's located in her lower back.
Yes.
Is she complaining of pain anywhere else?
No, she did not mention it to me.
Okay. And she has not taken any other medication.
Correct.
Okay. And you said that her daughter was with her.
Yes.
And she's okay with her daughter being with her. Okay. Well, I'll go in to see her.
All right.
And thank you for that report.
All right, and if you need anything, let me know. I'll be right out here charting.
Okay.
All right, thanks.
Thank you. Hello, Mrs. Banks. How are you?
I'm doing all right. How are
Good.
you?
I'm Nurse Practitioner Golson, and I'm going to be taking care of you today.
All right.
Ms.
Nice to
Tolliver
meet you.
did tell me that you came in for some pain. Can you tell me a little bit about that pain?
Everything hurts. It hurts if I'm touched. It's hurt if I don't touch. I told her it was a 10 out of 10 all the time.
Okay. All right. And so is no particular place that you hurt?
No, I mean, I definitely know that, like, in the lumbar area there's pain, but there's pain everywhere.
Okay. And I see that you're taking oxycodone and
Yes.
morphine, and they're not working for you?
The oxycodone is the only thing that actually works.
Okay.
That I know that actually works.
And tell me, when you do take it, how much relief do you get?
It's not instant, but it definitely does over time. You know, kind of come into effect. But that's the one that I know definitely does work.
Okay. And then based on your history, I know you've come to see us several times. We're looking at seeing how we can do something a little bit for you, that maybe some alternative medicine that will help with some of this pain, and so that we can get that under control. Okay?
Well, everything that y'all have tried to give me before don't work, so I don't want to try anything new. It doesn't usually. I have adverse effects that makes me anxious, and I'm not a fan of it. I've tried the CPAP, it makes me claustrophobic, and I just know that the oxycodone works. So I'd be much more comfortable if you just up the dosage of that, and then we can call it a day.
Okay. So why don't we'll look at making you comfortable. That's what we want to do, make sure that you're comfortable with your pain.
All right.
But we may want to look at some other alternatives, okay?
All right.
Will that be okay with you?
I mean, I'll hear what you have to say, but even physical therapy doesn't help. So.
Okay. So, and we'll talk about physical therapy. I'll tell you what I'm going to do. We're going to consult with Dr. Jones, and he and I will come together as a team, and we'll talk with physical therapy. I know that you have a history of TMJ, so we'll look at that as well, and see what can make you comfortable. Okay? All right. So I'm just going to listen to your heart and lungs, and then we'll have you come out, and we'll discuss more what your therapy and follow-up may be. Okay?
Right. Thank you. I appreciate it.
Hello, Dr. Jones.
Hi,
I'm
Dr.
Dr. Goldsmith, nurse practitioner.
Yes, good to see you, Dr.
Can I
Goldsmith.
speak to you a moment
Please
about
have
a
a seat.
patient? Thank you.
Excuse my not getting up.
Oh, no problem. Thank you very much. I'm
Okay.
glad you have a moment to spend there. We have a patient. Her name is Mrs. Banks.
Okay.
She is a 56-year-old female who came in today with complaint of high blood pressure and pain.
Okay.
She has visited our clinic numbers of times, and we are really concerned about her not getting real good relief from her chronic pain, despite the use of multiple opioids. Mrs. Banks is a retired high school teacher. She had a history of TMJ, fibromyalgia, and has also a history of a ruptured L4, L5. She also reports a history of assault that happened 25 years ago, in which she's currently been evaluated for disability for
Okay.
that. She has tried physical therapy, but states that it really doesn't work for her. Also, she's an antagonist for behavior therapy. Apparently, she's been fired a couple of times from the psychiatrist. She also has a history of alcohol problems, but has self-alleviated that. And in addition to that, her past medical history of obstructive sleep apnea, and she also has been showing some signs of opioid-induced hyperalgesia. We're concerned on her assessment today. She had a 10 out of a 10 pain level, blood pressure 150/96, and her physical exam was unremarkable. Her labs are also unremarkable. She had an MRI that showed just some degenerative disc disease that's appropriate for her age. And so my diagnosis today, I came up with, of course, with her chronic fibromyalgia. She also scored a 10 on her PHQ-9. And so I'm concerned that she may have some depression going on, and with the anxiety that she's having, that she also may have the PTSD that she's exhibiting signs of. So I'd like to get your opinion on what do you think we should do about her pain control and how we can address her PTSD.
This is excellent. Thank you very much for learning as much as you did about the patient. It will help us with our planning. You gave me her blood pressure as 150/96. Do you remember what her pulse was?
Her pulse was 88.
Okay. And that becomes important because if we're talking about someone that's over-medicating with opioids, then you don't get a discordance between the high blood pressure and the pulse rate like we see here.
Right.
Usually if the pain is causing the blood pressure to go up, you get a rise in pulse rate. So what we're seeing probably is somebody that's had a long-term use of opioids,
Yes.
which is keeping the pulse down, but has an inherent basic tension underground. So I think we've got an interesting patient here. Was there anything remarkable in your physical exam?
I did notice that when I did touch her, she tended to cringe a little
Yes.
bit. So I'm concerned that she might have a little bit of allodynia.
Yes.
And so I also noted that in my my documentation on her.
Yes.
So at this point, I'm just wondering if we could perhaps have a team meeting to perhaps talk to physical therapy, to psych and pharmacy to see what we can do for this patient.
That's an excellent idea. Complex patients like this are very difficult to manage, needless to say, but we've always got to think about what's in the patient's best interest.
Yes.
Okay, and at this point, just prescribing medicines would not help her. Helping our working as a team to come up with a way to help herself.
Yes.
Get some shared decision making in the process would be very helpful. So thank you very much for bringing that up, and I think that's the next step for us.
Great. And if you can also consider speech therapy, because she did have a little bit of a slur, and she said she's had that history of TMJ.
Yeah.
So I can make that arrangement if you would like, and we can perhaps meet on Tuesday of next week.
That would be wonderful.
Okay.
You mentioned about the slurred speech. With the hypertension, you always got to think of a possible cerebrovascular event.
Yes.
So you got to think about intracranial bleed, and there's nothing on the MRI to suggest that she may have had a bleed or something.
Yes. So her MRI was unremarkable, with the exception
Good.
of the
I always like to
degenerative
ask that
disc
again.
disease. Yes.
Okay.
Yes.
Thank you, because when I hear slurred speech, the first thing I think about is stroke.
Right.
You
And I
know.
think it may have been just getting related to
Yes.
her
Okay.
TMJ.
Well, it sounds like you've done an excellent job with your foundation. I concur with you that our team coming together would be the
Okay.
best way. It would be the most effective way to understand what's going on with her and to come up with a plan that can help her to work going forward.
Well, sounds good.
Thank you so
Dr.
much.
Jones.
Thank you so much,
Okay.
Dr. All righty. Good afternoon, everyone. I'm Dr. Jones, and I want to thank you very much for joining this afternoon. I know that you've had a chance to hear about this complex set of challenges that this patient is facing. So it was important to convene the team so we can come together and how we can use our resources to best aid her. And this is a large health center, and everybody may not know everyone. So I'd like for us to just go around, introduce ourselves, and say what our role will be, and then we'll begin to discuss Mrs. Banks.
Okay. My name is Sherry Golson, and I am the nurse practitioner who's taking care of Mrs. Banks. She has presented several times to our clinic with multiple issues and chronic issues. And so my concerns for Mrs. Banks today is multi concerns, because she has a lot of pain, and I want that to be addressed, as well as her issue with her multiple use of opioids.
Okay.
Good afternoon, everyone. Hello. My name is Tawanda Tolliver. I'm the registered nurse that works in the clinic alongside with Dr. Golson. And I'm pretty much here just to answer any questions in regards to the patients that you may have, kind of help you navigate through her chart if you have any questions.
And I am Patricia Richard Sproul. I'm the pharmacist on the team. I reviewed her medications, and I do also have concerns about her opiate use. I have concerns about an optimal medication dosage for her, as well as safety factors with opiates.
Yes.
Good afternoon. My name is Zenobia Crawford. I'm a physical therapist. And in reviewing the case, I was quite concerned that the patient had a negative response to physical therapy, obviously something we never want. So I would like to be able to provide some options. I think when someone has pain, especially if they're on opioids, the American Physical Therapy Association has a big campaign currently against the use of, well, not so much against the use of opiates, but alternative to opiates. We have a number of treatment options instead of opiate use, and also in terms of exercise. So hopefully I can help provide some assistance and maybe get her back involved in physical therapy. I think physical therapy would be a great option for this patient for many reasons.
Well, thank you for that. And one of the interesting things I'd like to do is give us a solid foundation about Mrs. Banks so we can all be on the same playing field. Because we were very fortunate to get an excellent write-up of her last visit. And we've had an opportunity to look at different things in her past medical history. But so Mrs. Banks is a 56-year-old female who presented to clinic 2 weeks ago for a follow-up on a high blood pressure. And during the course of that visit, we noticed that she was very, very tender and sensitive to pain in her low back region. And that's when the dialogue occurred, and we found that there were several things going on with her. She also has a history of fibromyalgia. She has a history of lumbar 4 and 5 challenges with a ruptured disc. She was the victim of an assault 25 years ago, and is currently doesn't work and is going through the process of evaluating for disability. So she has tried behavioral therapy in the past because of increasing dependence on opioids and found that that didn't work. And what she asked for at this last visit is, I don't really want anything else, just up my medicine and let me go. And you know that's not necessarily a good sign. Her presenting vital signs was she had a blood pressure of 150/96 and a pulse of 88. Now, I'll share with you that there are a lot of people when someone is using higher doses of opioids who will say, well, maybe her blood pressure is elevated because she's in pain. Well, in reality, you will see an elevation of her pulse before you see the elevation of her blood pressure. So it suggests that she may have pain, but she may have other conditions going on with it. So she's going to present a significant challenge for us. Lastly, I'll say that her medications are opioids, oxycodone, morphine, hydrochlorothiazide, and she's been tried on diazepam. So I'd like for us to take a moment and dialogue about this very complex patient and see what we can do to help to move her to being able to have a normal quality of life.
So my concern was that in addition to her having the fibromyalgia, she also had some allodynia. During the exam, I did notice that. And I also noticed we did do a PHQ-9 screening test on her, and she scored her 10, which is moderately high for depression. And given her history of being of her assault, I'm concerned that she may have also PTSD. So if we can address maybe make a referral for her for a mental health evaluation. I think that would be appropriate given her situation there. But, and also if we may even consider some other alternative modalities in regards to her pain control. And I'm hoping that pharmacy will be able to give me a little bit more information in regards to the type of medications that we can prescribe for her.
Okay. Well, in reviewing her EHR, she does have some medication-related problems that need to be addressed. First of all, her blood pressure is uncontrolled.
Yes.
She's right now on hydrochlorothiazide once a day. So our recommendation would be to increase it to twice a day, keeping in mind that we would need to monitor her uric acid levels, her serum electrolytes, her glucose, and her renal function. And also we would follow up with monitoring of her blood pressure. Next, we're looking at her hypolipidemia. And we noticed there are not any recent lab values. So we'd like to get some recent lab values because right now she's on atravestin, and we have concerns that the atravestin may be causing a possible rhabdomyolysis that could be contributing to her pain. So we don't want her on a drug that's also contributing to pain.
Yes.
Okay.
So we would like to repeat the lipid panel, check her serum creatinine kinase to check for that.
Yes.
Of course, we know her biggest issue, doubtless, is her pain management.
Yes.
She has a history of fibromyalgia
Yes.
with an intolerance to TCAs and SSRIs and degenerative disc disease, which is managed right now with the opioid analgesics. Our concern is she's on more than one opioid. So our plan as a team is that she has realistic expectations about her pain and her prognosis. We can't cure her, but together we can significantly improve her function and her quality of life. So what we'd like to recommend from a pharmacist's perspective is to begin to taper her opiates.
Okay.
So our recommendation is to have her on only one opiate, to have her on oxycodone ER, 30 milligrams, not BID, but TID. Hopefully then she won't have the breakthrough pain to need an immediate release opioid. And slowly taper that over several months for an optimal minimal effective dose for pain control. There could be some problems with withdrawal. In order to offset the withdrawal, we recommend that she be on clonidine 0.1 milligrams 2 to 4 times daily as needed, and also promethazine 25 milligrams every 6 hours for any associated nausea and vomiting. Now, we realize there's a safety issue with patients being on long-acting opioids, and she's also concurrently on a benzodiazepine therapy.
Yes,
So we definitely recommend that she needs to have a naloxone rescue kit
yes,
with an intranasal adapter. We would then educate not only the daughter, but the husband as to how to use this antidote in the case that there's a problem. We also need to ensure that the patient understands that these serious safety concerns are the reason why we're tapering her
Yes.
opioid medications, because we know she's been resistant to that in the past, but we need for her to understand these safety concerns. Finding the right dose of pain medications will be an important part of her being able to participate in her planned activities and goals. We
Yes.
understand that she wants to be a caregiver for
Yes.
her in-laws. She can't do that right now. So if we're able to taper her opiates until she is in a place where it improves her mood, her sleep, her function, and her overall quality of life, once again. But optimizing drug therapy is just a part of helping her pain improve. We cannot manage her fibromyalgia pharmacologically without additional drug therapy, which she's already said she does not want. So we need our physical therapy colleague to help us in designing an exercise plan that would help her to relieve her fibromyalgia-associated pain.
Okay, we would love to help her. First off, in reviewing the records, the patient reports physical therapy. Probably we will need to get the medical records, if possible, that will give the evaluation and what type of physical therapy program she had. We will also recommend Dr. Jones that she is referred for a physical therapy evaluation, a complete evaluation that's going to look at all the different systems, musculoskeletal, cardio, integumentary, neuro. We'll do a complete evaluation. This patient, in reviewing the record, appears functional. She's moving about her house, moving about her community, wants to be able to do more, but is limited by pain. So we really need to get in and get a good overall assessment of what her movement system is and where we can intervene. Certainly one area that's going to limit anyone's movement system is pain. And we have several clinical modalities to address pain. We could use any of the heat modalities, something as simple as a hot pack, massage, or ultrasound, or even pool therapy. I would probably think pool therapy for this patient because it's usually very relaxing. And so it could address issues of fibromyalgia, which can affect a patient all over. And so the water can be very soothing. The next thing about pool therapy is that you're able to move.
yes.
And so she would have the buoyancy of the water to assist with movement through full ranges, with hopes that maybe transitioning her out of the water to exercise and ultimately getting her involved in some type of community program, yoga, Pilates, something that's going to help her with movement as well as strengthening so that she has something long-term that's going to get her body system, movement system stronger and hopefully decrease the discomfort. So I think there's a lot that physical therapy could offer. But I would really, really suggest, number one, we do the evaluation, get the background information so we really know what we are dealing with. And the other part is that the evaluation will really set the tone of where we should start and what we should do. I think, I've heard this a lot, patients don't like the discomfort, and I understand, because when if something's uncomfortable, I wouldn't do it either. So our biggest challenge here is going to convince her that we can start off and make her feel good, and then move into some of the other therapeutic exercises that may be a little more challenging, but do it in such a way that the patient intrinsically wants to do it. Not extrinsically, I'm forcing you to do it, but she begins to see the benefit of moving and how it will help not just the fibromyalgia, but her lower back pain, and get her moving toward participating at home and caring for her loved ones, as well as being active in the community. I really would suggest a complete physical therapy eval.
Well, thank you for that input. And Ms. Gaynor, we're going to talk about some of the things that we'd like to put as a part of the plan, and I'd love to hear your thoughts about how to present this to the patient, because you know her best out of all of us. And it was really good to find out that when Dr. Goldson saw her, she was able to assess her physically and then pick up on some things that weren't necessarily stated and raise some questions that led to us coming today. Excellent way to lead to the way to get what's best for a patient. Then when we dialogued about our history a little bit, and we learned from our pharmacist that there were some red flags there. And we talked about the need to treat the hypertension and do other things. Interestingly enough, when you started talking about managing other medicines, and in addition to a hydrochlorothiazide, you added clonidine, and clonidine will have an effect to help lower her blood pressure as well. So even we're getting in the process that without necessarily targeting the blood pressure, we're bringing other things together. It's a tremendous way of doing it. And then and you raised another component about safety. When you have someone on multiple opioids and they're driving, they're a risk to the community. So these are the kinds of things we have to dialogue about that would help the patient to know that we need to do what's in their best interest. I love your offer. You're bringing the idea for the naloxone at home and training the family to use it. It's a rescue situation, and you never know when it's necessary. And lastly, I love the fact that we're talking about the different modalities for physical therapy and even some components of occupational therapy associated with it that helps her not only make sure she's alleviating her pain, but to help her to integrate herself more into her community. I'm particularly concerned about something you mentioned, which is to help to make it less painful right away so that she doesn't turn to complementary and alternative medications. Because complementary and alternative medications may interact with the other medicines that we're using to control things. So we've come together as a team, and we've come up with an approach that's reasonable. I subscribe to believing that each of the things you recommended would be in her best interest. And so, Dr. Gaynor, I'd like to know what your thoughts are about how we can go about really engaging this patient so she can own a part of patient-centered care and patient-centered decision-making.
Well, thank you, Dr. Jones. Actually, I agree with the recommendations that the team has made. I wanted to add one other recommendation, and that is to involve nutrition. I think that it would benefit her. She did mention that she was interested in losing weight, and I love some of the recommendations that you talked about, particularly with yoga, because she said she likes to dance and she's very active. But in one conversation I had with her, she said it was very painful. So I think some of these alternative modalities would definitely work, and I think she would be interested in it. And also, I think just to make sure that we have good follow-through and keeping all of the plan of action together, I'd like to probably recommend case management or care coordinator to kind of oversee the plan, and that way we can make sure that there's some consistent follow-up with her in regards to the plan that we've discussed today. My question now is just when do we want to get her back so we can give her this information? And I think sooner would be better.
I think that, I understand she's scheduled to come today, so we can invite her in this afternoon and we can sit down and just introduce ourselves and begin to discuss some of it. But I'd recommend after we discuss the plan with her that we reconvene when we've had the for anything we do to begin to have a meaningful impact. So why don't we plan and to see her in 4 to 6 weeks follow-up, and that way we'll have the data and we can plan on where to go from there.
And
Great,
Dr.
and
Jones, just to be clear, do you want her to schedule an appointment with me for a 4 to 6 week follow-up?
I would recommend that, since you're concerned about the level of her blood pressure right
Yes.
now, I think you might want to see her sooner
Okay.
based upon the interventions to control the blood pressure specifically. But in terms of reconvening our team, we'd say 4 to 6 weeks.
Okay.
Okay?
And I'd like to bring case management and maybe
Yes.
during this next meeting so that she can kind of be aware of what's going on as well.
And let's place in the back of our minds that she is a PTSD patient, and we've got to find a way to accept some behavioral help intervention. And also, she's a chronic pain patient. And you put the two of those together, and they're automatic setup for depression, as you said, but they also makes them resistant to other things. It's a trust factor. So we're going to have to make sure that we overcome that barrier as we take care of her as well.
Exactly.
Thank you so very much for being here
Thank
today.
you.
This
Thank
is what I
you.
call a
Yeah,
real good
thank you
team.
very much.
Absolutely.
I
Pleasure
enjoy
meeting
working
you
with
all.
you all. That's
Thank
a
you.
wonderful thing.
Thank you.
Thank you.
Forward
Sounds
to
like
it.
we have a plan.
Yes.
Well, good afternoon, Ms. Banks. How are
I'm
you?
doing all right, Nurse T. It's nice seeing you
I'm
again.
good. I love that blouse you have
Thank
on.
you.
As I mentioned earlier when we last spoke, that we're going to get together the healthcare team to talk a little bit about some of your care coordination needs. I'm going to allow the team members to introduce themselves. I'm sure you remember Dr. Golson.
Hi, nice to see you again today, Ms. Banks.
Likewise.
And again, I'm the nurse practitioner on the team, and we're here to really discuss your patient care, and we want you to be the center of our discussion and have input on your decision-making in regards to taking care of your healthcare needs.
Thank you.
And hi, I'm Dr. Jones. I'm the Chief Medical Officer, and my job will be to help to look at your health conditions and try to figure out a way that we can get you to where you want to be.
Thank you, Dr. Jones.
Hello, Ms. Banks. I'm Patricia Richard Sproul. I'm the pharmacist on the team. And I understand you have some concerns about your medication. So that's why I'm here.
Thank you so much. I appreciate you.
Good afternoon, Ms. Banks. I'm Dr. Zenobia Crawford. I am a physical therapist. And I understand you have a lot of concerns about physical therapy, and I hope I'm able to address some of those concerns and also give you a lot of information about the many, many options in physical therapy.
I appreciate
So I'm
that.
here to just help you.
Thank you. I appreciate it.